morning, everyone, and thank you for being here this morning. I wanted to thank Norma Freeman for bringing this program to our attention this morning. Thank you, Norma. JCC also welcomes the opportunity to bring the universally relevant topic of advanced care planning to the community's attention. Given last month's Supreme Court of Canada's unanimous decision to strike down the ban on providing doctor-assisted death, the topic of having important conversations about one's palliative care wishes brings with it a renewed sense of urgency. Today's speaker, Louise Hanvey, is the Project Director of the National Advanced Care Planning Project in Canada. Advocating for the advancement of hospice palliative care in Canada has been the focus of her efforts over the past 7 years. Pallium Canada is an organization that supports a collaborative approach to the education, engagement, and standardization of palliative care in Canada. It's my pleasure to call upon Rabi Reuven Bulka, member of the Board of Directors and first Vice Chair of Pallium Canada, to introduce Louise Hanvey.
Thank you very much, Ross. You know, it's a Jewish event because you have an introducer to introduce who's going to be introducing. That's the way it goes. I know that you've already done it, but this event would not have taken place without Norma Freeman. She had the vision, then she had the drive, and then she put it all together with the SJCC. So I would like to begin by having us all give her a nice round of applause. The issue of advanced care planning is one which reminds me of an interesting event that took place here in Ottawa. I don't remember how many years ago, but it's sometimes bad to have a memory of things. Years and years ago, the Chevra Kadisha, which, as you know, is the society responsible for end-of-life care, that is, after a person has died, life has ended, to issue a proper burial according to Jewish law. They send out a brochure to the entire community about how to, what to do when a person passes away. And I remember then the uproar within the community. People were absolutely outraged. How dare you remind me of the fact that we are all mortal? And they basically said, we will call you when we need you, till then don't bother us. This is actually an event that took place in our city years and years ago. But things have changed. And now we think in terms not so of advanced care planning as a normal thing, except that we're still a little bit queasy when it comes to the real end-of-life care decisions. And most people today, when you ask them if they have made up a will, no matter what age they are, they say either they have or they're in the process of doing so, but they know that they have to. You don't usually hear people putting it off and saying, I'm not going to do it, I'll wait till I have to. And things also have, the world has become a little bit more complicated. A lot of the things that we're doing today, our ancestors couldn't have dreamt of. So just a simple little thing, you know the word DNR? Mm-hmm. It used to be a short form for a donor. Right? A philanthropic word. Now today DNR is a totally different connotation. And when I grew up, the idea of DNR being an issue wasn't even on the table. But there's so many things, the world is offering us things that we couldn't have dreamt of before, including music when I speak, which is great. And it's no problem. So the idea of doing this is very important, and the idea of having someone who really knows their oats to talk to us about it is also very important. So my great pleasure in introducing Louise Hanvey is also coupled with the idea that after she speaks, for as long as she wants, I will just pipe in with a few observations of a Jewish nature on her presentation. We have not shared notes up until now, so I have no idea what she's going to say. I just know from Norma that what she ever is going to say will make a lot of sense. Ross has already given you a little bit of an idea about her. She is passionate about this, which is absolutely more important than anything else. An RN She's had clinical experience in hospital, in the community. She's been involved in palliative and end-of-life care issues for many, many years. If I tell you all the things she's involved with, you probably forget in a minute or two. So it's really not that important. Important to know is this is a lady who cares. This is a lady who's deeply involved. She's married. She lives in Chelsea. She's going to be on my radio program tonight. So those are all good things. A great pleasure to introduce Louise Hanvey.
Very much, Reverend Bulka. It's really my pleasure to be here this morning and to see so many people in the room. I'm delighted that so many of you took the time out of what's finally a nice weekend to come and listen and share and think about the things that I'll talk to you about. And so I'm using slides, and primarily they're a prompt for me. We're videoing. People can, look back at the presentation if they want. I've also brought some handouts that you can take away that sort of reiterate what I've said and add some more information as well. And so I'd like to start by asking people in the room, before you saw the flyer and decided to come this morning, how many of you had ever heard about advanced care planning or the words advanced care planning? Okay, so that's pretty good, because when we did a poll, we found that 86% of Canadians had never heard of advanced care planning. And so what I'm going to do this morning is I'm going to talk a little bit up front about why this is important, but then I'm going to get to the nitty-gritty of what advanced care planning is and how we do it, the steps, and some of the things you can think about. Because I'd like to say up front that advanced care planning is a very personal thing. In many ways, it's an intimate thing, and it's a sensitive thing, and I think that's why we have trouble talking about it sometimes. So I'll give you some suggestions, some ideas, some practical tips that then you can integrate into your own life based on your own values and work with. And then we'll have lots of time for questions if people have questions. So up front, I'd just like to give a little definition of what advanced care planning is, but then we'll talk in detail about what that means. Because there's a lot of misunderstanding about this out there, and a lot of people have misconceptions about what this is and what it isn't. So basically, what advanced care planning is, it's a process where we think about our values, our beliefs, and how they will influence our wishes and what our wishes might be for our care in the future, when or if we get sick, when we're facing the end of our life. What would our wishes be in the context of our lives for our care? And then very importantly, deciding who will make decisions for us if we can't make decisions for ourselves. And I'll talk about that in detail, what that means. And having a conversation with that person and other people. So advanced care planning is thinking about values, expressing wishes, and having conversations so that in the future, if I can't make my own decisions, the people who will be called upon will know what I would have wanted. And so it gives us some opportunity to have some control over our future care. I'd like to start with a bit of a personal story. That's my mom. And my mom, her name is Lillian, and she died in 1993. So she died 22 years ago now. And I had no idea what advanced care planning was. I worked in obstetrics then. I worked on the other end of the life force. But my mom taught me a lot without ever using those words, and she gave me a gift. When my mom was diagnosed with cancer, or actually prior to that, my mom, when she was a young woman, when my sister and I were little, was very ill. She had celiac disease. Nobody knew what that was. She almost died. And she told me, when I was old enough to understand, she said, I said to God, all I want is to live long enough to see these two babies grow up and be okay. And if I can have that, I'm going to be okay. So she told me that probably when I was, in my teens or 20s, and we talked about it. When she got diagnosed with cancer much later in life, she talked about that again. And she lived with cancer for a few years, and she made her treatment decisions based on that and other things that she valued. When it came to the end of her life, we were very lucky, she was cared for in palliative care. This was in Winnipeg, very well cared for. We had lots of conversations in our journey from the time she was diagnosed to there. So my sister and I knew very well what she wanted at the end of her life. And we respected her wishes, and we were able to support her and have her wishes met. And I have to say, and we say this to people, that advanced care planning is a gift to your family, but I have to say from a personal point of view, she gave me a huge gift, because I'm at peace. I miss her today. I miss her, many, many times when one of my children does something outstanding, I think, oh, my mom would have loved that. Or if they're really struggling, I think, oh, my mom would have really helped me right now because I don't know what to do. But I'm at peace with the end of her life, with how she died, and I know it was what she wanted. So I wanted to start with a personal story because this is all very personal and intimate for us. So why should we care about this? Just a few simple facts. I won't go into great detail. We are living longer, but we're all going to die. We actually, I should have said this up front, sorry. I manage something called Speak Up, Start the Conversation About End-of-Life Care at the Canadian Hospice Palliative Care Association, which is a national advocacy organization for improved access to quality palliative care. And one of the things we do in the program is we create these infographics that are things to grab people's attention, and one of them says 100% of Canadians will die, because we all will die, and that is a given. And most of us will die with a chronic illness. And so we'll have a long time to plan. Only 10%, less than 10% of Canadians die suddenly. Most people die with one or more chronic illnesses. So that there is time to plan, and it's important to plan. So healthcare decisions are getting very complex. Technology, the world we live in, science and all of its advancements are making healthcare decisions quite complex. We've heard a lot about recent cases in the news, very high-profile cases, legal cases where decisions became very complicated. And so the more we can think about things ahead of time and plan, the better off we'll be. And as I said and showed from my personal experience, advanced care planning eases the burden on our loved ones because they don't have to guess and say, I don't know what mom would have wanted. I don't know what to do. It's not to say that the decisions become easy. They don't. They're hard. They're always hard. They're complicated. But there's a certain sense of peace that comes with knowing what your loved one would have wanted. We have really good research evidence now. Really, it's recent. It's accumulated in the last 10 years, but it's not disputable. The question is not if we should be doing this anymore. We know that if we do advanced care planning, we are more likely to have our wishes known, but more importantly, followed at the end of our lives. So we get what we hoped what we could get. That's more likely to happen. Now, as I said, we always hear about the high-profile cases where this doesn't happen, but if we do advanced care planning, it's more likely to happen. Our family members are less likely to have stress and anxiety around the time of death at end of life, and also in the grieving process. We're more satisfied with our care. Our family members are more satisfied with our care. And most importantly is people that do advanced care planning tend to have a better quality of life and death. So who needs to do it? Everybody. We don't know what the future will bring. We don't know when we might get sick. We don't know when we won't be able to speak on our own behalf, when somebody else will be called on. And we hope that we can talk to the very end and direct our care, but it doesn't always work that way. And the research has indicated that with hospitalized patients, and the majority of Canadians still die in hospital, although that is shifting, but with hospitalized patients, the majority of them, almost 3/4, were incapable of making their own decisions at the end of life. So it's something certainly that is real. And so what happens when we don't have these conversations and we don't do it? This is a quote out of a Canadian research project that we're involved in. And she says, "I didn't expect him to die so soon. My husband resisted talking about dying, and after 40 years of marriage, I feel he let me down by not opening up. And I guess I did let him down for not knowing how to talk to him about some of the things that I needed to discuss. It would have been nice closure if things had been different in the end. I can never get that time back."
Wow.
And it's not just for old people. A young woman that approached us, Belinda, said that death happens when you're older, right? Wrong. Almost 3 years ago, my 20-year-old friend was diagnosed with cancer. She passed away this past fall. For me and other friends, this was a shock. It never crossed my mind that this was a possible outcome. Before Christmas, there was quite a bit of, in the news, a physician in the States by the name of Atul Gawande, he's just written a book on how the medical profession doesn't deal well with talking to people about death and dying. And he was on The Current on CBC Radio in the morning, and they had more letters about that show than they'd had about any show in a long time. And we wrote a letter, and we were invited to come on the show in follow-up to carry on the conversation. And I was on the show with a young woman named Anna, who's 38 years old with 2 small children, who is dying of metastatic breast cancer. And Anna talked about her values and what was important to her as she lived out the little remaining time that she had. But she also talked about how people aren't talking to her about this. Her friends can't talk to her about it. Her family's friends can't talk to her. Her oncologist didn't talk to her about it. Now, luckily, they did make a referral to someone who is talking to her about it. Excuse me. But I was profoundly moved by how Anna was so open and articulate about why it was important to talk. And her values were clear, and they had to do with her children and her legacy for her children and all of that kind of thing. But she was very articulate about how it doesn't matter how old you are, we need to talk about this. So now I'll just talk a little bit more about what advanced care planning is and how we do it. So some people think about advanced care planning that it's a piece of paper, it's a form, it's a checklist, it's a living will, which I'll talk a little bit about what that means. That it's just sort of a one-shot deal. I write down, okay, I want this or I don't want this. That's not what it is, and that's certainly not what it is in Ontario under our legal context. So it's a process where we reflect on our values and beliefs, and it's a time to let others know. So it's conversations. It's reflection and it's conversations. And it's planning for future care when you are no longer capable of making your own decisions. So there are 5 steps to advanced care planning, and for the remainder of the presentation, I'd like to walk through those steps and give you some concrete ideas about what you can do around each of the steps. And I've also brought some workbooks that are very specific, again, to the Ontario legal context that you can take away and look through, and all of what I'm talking about is reflected in the workbook. So I have a short video. So the people we've worked with across the country to try and come up with an easy or a straightforward way of thinking about this, we've all sort of came to the 5 steps. And so I'll work through them with you. And just to recap what you saw in the video, first step is to think about your values, your beliefs, your wishes regarding future healthcare choices. And then learn about the medical information that's relevant to your particular situation. The kinds of treatments, procedures you might be facing, and what the risks and benefits might be. Very importantly, decide who your substitute decision maker will be. And then talk with all of the people in your circle who are important. Very importantly, your substitute decision maker, they need to know your wishes, but your family, friends, healthcare providers. And then you can record your wishes if you like, either by writing them down, by doing audio or video recordings. So this is the most important step. Step 1, thinking about our values and beliefs. And people say, well, what does that mean? And so we have some specific things to think about and questions that can help guide that process for you. And one of the first ones is, what makes my life meaningful? And remember, I said earlier on that everybody needs to do this, and it doesn't matter what our age is, and it doesn't matter whether we're healthy or ill. Everybody needs to go through this process. So we need to think about what makes our life meaningful, spending time with our family and friends, faith, and the things that we love to do, garden, music, art, whatever that is that what makes our life meaningful? What brings me happiness every day? What makes me get up in the morning? What do I look forward to most every day of my life? And these may seem like, well, what does this have to do with what I want if I'm lying in a hospital bed and can't speak for myself? But if we express these values to our loved ones and our substitute decision makers, when they're being called upon to make very difficult decisions on our behalf, this is the frame of reference and this is the context that they'll make those decisions in. And then the next step in the process of reflection is thinking about your health. And so when we're doing the think step, we're thinking about our values and life meaning and the very big picture. Then we're thinking about our health and well-being and sort of how that all fits. And then the third part of it is we think, well, what about when I'm dying? What about the end of my life? So there's sort of 3 parts to the thinking. So thinking about my health, what do I value in terms of my health right now? And remember that this is a process, so we revisit this and it changes as we get older, as our life situation changes, as our health changes. So is it to live independently? Is it to make my own decisions? Is it to have a good meal? Is it to be able to communicate with others? Being able to recognize people? And to have my privacy upheld? And again, some people think, well, you know, having a good meal, what does that mean? But Atul Gawande tells a good story about a man who had, you know, expressed a lot of his values to his kids, and one of them was that he really liked to have beer and watch the football game. That was really important to him. And so he was lying in somewhere, an intensive care unit or somewhere, unable to communicate, and his kids were being called upon to make decisions about life-sustaining measures, so very critical decisions. And they said, you know, if we do this, is he likely to get to the point where he can drink beer and watch football? And they said yes, and he said okay. And so that may sound like an oversimplification, but it shows how talking about our values can help people think through what we might want. And then, you know, when we express wishes and we think about wishes, wishes are sort of often what-if scenarios. We cannot possibly anticipate every scenario we are going to meet throughout our life or the end of our life. And that's why simple written documents that say, I want this, I don't want this, often don't work. They certainly don't work in Ontario because they're not what the healthcare providers look at. But even in other jurisdictions, they don't work because context changes and what happens changes. But we can express wishes, and we can think about what if something happened, what would I like? And again, our substitute decision maker can have that in their mind as the context for making a decision. So how would I feel if I were confined to bed all the time? How would I feel if I had pain or symptoms all the time that somebody couldn't manage? How would I feel if I were confused all the time? How would I feel if I didn't have control of bodily functions? Or if I couldn't communicate in a way that people understood? Or I couldn't have meaningful relationships with my family and friends? And some people think about these statements sort of on a continuum. So if I were confined to bed all the time, how acceptable would that be to my life? Well, it might be very acceptable, or sort of acceptable, or not at all acceptable. And by just expressing those simple things, not saying, not giving somebody a directive of what to do if I'm in bed all the time, but just how would I feel about that, again, we'll give our substitute decision maker information to work with. And then we can take it even further. How would I feel about being kept alive with machines if I had no chance of survival? How would I feel if I were in a coma and not expected to wake up or recover? What would I want? What would my wish be? If I have a permanent and severe brain damage and not expected to recover, what would my wishes be? Again, we can't anticipate the reality of this. If we're sitting here, healthy people that can drive to the community center on Sunday afternoon, necessarily, but we can think about it in broader terms. And then remember, I said the third part is thinking about end of life. And this is sometimes the hardest part for people. As we heard earlier, people don't want to talk about this. In the poll that we did, where we asked people why they thought, you asked Canadians why they thought people didn't talk about end of life, almost half of them said because they didn't want to upset their family. And remember, to my personal story, to the evidence that we see, we're actually doing the opposite when we talk about these things. We're giving our family a gift of knowing what our wishes are. The other reason was that they don't think it's real. I think more than 40% said, well, it's not relevant to me. We're all going to die. Maybe not imminently, and maybe we have no reason to believe we're going to die imminently, but we will all die. And then about 40% said because they were creeped out by having the conversation. So this can be the hard part of the conversation. And so the kinds of things that you need to reflect on before you even start having these conversations with people. What would make my end of life better for me? What would it look like? What would make it better for me? If I had my family and friends nearby? If all of my religious rituals were honored? If my religious leader was close by to me? If I could hear people talking about how my life made a difference? If I could listen to music? If I could have an open window? We can think of a lot of different things that would be important. If possible, would I prefer to die at home, in a hospice, or in the hospital? And what might change my mind about that? And again, as I said at the beginning, this is a process. So I might say, my preference is to die at home. But then as time went on, if the reality of that became such that it was very difficult for my family, I wasn't able to sort of have the circle that I needed, I might change my mind about that. So it's important to think about what would I prefer, but what would change my mind? And then what are my fears? When I think about dying, what am I afraid of? Struggling to breathe, being in pain, being alone, losing my dignity. Again, if we think about these things and reflect on them and talk about them, people have a sense of what we would want. And very importantly, who can I talk about those fears with? And so what's going to influence, what are the important influencers of my wishes for my care at end of life? My religious or spiritual beliefs? How will that influence what I choose or don't choose, what I want my substitute decision maker to choose or not choose? And what previous experiences have I had? Many, many people have perceptions or perhaps even fears of dying based on their previous experience or lack of experience. When we did the poll of Canadians, very few Canadians had had sort of personal, caring experience with death. It's something that in our society is often removed from the family, from home, and placed in a different context. So maybe I haven't had any experience with a dying person, or maybe I've had a bad experience. Somebody who died in pain is often the story that if people share bad experiences, that's the bad experience they share. Someone who didn't get, for example, the kind of palliative care and support that my mom got. So what experiences have we had? Because that will certainly influence what our wishes are. And then there's many others. So that's the first step, and that's the hard step. And it's important that we do that step. Start it on our own, certainly have conversations about it, and I'll talk more about that. And revisit it over and over because our situation changes. The next step is to learn. We need to know what things mean, what's out there, what might be important for us. So even if we're in good health, it's important to know that people know our wishes, because our health status can change suddenly. And it's particularly important to do this work if we have a chronic illness, because most chronic illnesses, cancer tends to progress in a certain sort of slow decline way, although there's different cancers and different experiences. But other chronic illnesses like heart, lung, kidney tend to be more erratic and less predictable in how they go. And people get sicker and better, and then sicker, and then might die. So we really don't know always with a chronic illness. So obviously your physician or your nurse practitioner or your healthcare provider is a good person for this information. And if you have an illness, if you have a chronic illness, it's critical that you talk to your physician about it, about your condition and your prognosis, what you're expected to experience in the future. And there's not an exact science to prognosis, and they're always trying to perfect it and do the best they can. But it tends to be, a probability thing. But usually you can have a conversation with your physician about what does this illness usually look like? What am I likely to experience? And then possible medical treatments that I might need to make decisions about so that I can understand them. So just some pointers of how to start this conversation. What we found, we did some research with family doctors and oncologists, and a large proportion of them feel ill-equipped to start these conversations, and they don't start the conversation. And I've had lots of family doctors say, we would prefer our patients come and start the conversation. There's still this fear of destroying hope. So if I'm a doctor and I say to you, you're healthy, but I want to talk about what your end-of-life wishes will be, is my mind going to go to, oh my goodness, there's something they're not telling me. I am dying. And in fact, the research shows us the opposite, that it doesn't destroy hope, and it actually does all those other good things I had, but it's still a perception. So in many cases, it's better for us to go to our family doctor or our oncologist or whoever specialist we're seeing and have these conversations. So what can I expect from the illness? What's it going to look like 6 months from now, 12 months from now? Those are questions that people can usually answer. How will it affect my ability to function independently? What changes can I expect that I need to be prepared for? And will I improve or not improve if I choose certain treatments? And what can I expect if I do nothing? So just some questions to guide the conversation. And when you're gathering information about your health context, if you're doing advanced care planning in the context of having an illness or a chronic disease, it's several conversations. And it's different depending on your situation. But every conversation you have with your family doctor or whoever's caring for you helps them understand your wishes and your values better. And you, as I said, you don't have to wait for your doctor to bring it up. And having these conversations in a crisis doesn't work. And I have another short video that I'll show you where doctors and nurses are talking about what that looks like. So while it always seems too early, don't wait until it's too late, because it doesn't work. And that's when people get into difficulties. Okay, so step 3 is probably, well, under Ontario law, it's the most important thing about advanced care planning. And that's deciding on who will speak on your behalf if you can't speak for yourself. And we call it a substitute decision maker. That's just a word. So a lot of people don't understand this. This is the law in Ontario. If you can't make your own decisions, and I'll talk a little bit as well about what being capable means, but if you can't make your own decisions, your healthcare providers must turn to your substitute decision maker. They can't turn to a piece of paper. So although we recommend you record your wishes, you need to share that with your substitute decision maker. Because your doctor, the doctor in emergency, the doctor in the ICU, doctor in the hospice, turns to your substitute decision maker. So it's critical that your substitute decision maker know what your wishes are. And they only can answer those questions if you can't answer them for yourself. And they can guide your care and advocate for you in your best interest. So I just want to talk for a minute, and I'm not a lawyer, so I don't want to get into, I don't have the skills to get into all the legalities, but I understand what capacity means under the law. So in order to be capable, I need to understand what somebody's telling me, and I need to appreciate what it means for me. So I need to appreciate, so if somebody says to me, CPR means, doing compressions on your chest to get your heart beating again. So I need to understand, okay, that's what that means. But what if I have CPR? What does that mean for me? What's the outcome? Am I going to live? Am I going to live longer? Am I going to live? So I need to be able to appreciate the information as well as understand it in order to be considered capable. And so I need to be able to understand the likelihood or the outcomes of the decision. Now, something else, you're not deemed incapable, or people aren't deemed incapable for everything all the time. You can be capable for certain decisions and not for others. And you can be capable at one point in the day and not capable for the same decision later in the day. So it's not a sort of a one-shot deal that someone's completely deemed incapable. I mean, in some situations it is. If you're in a coma and you can't speak, you're not capable. But it can be more nuanced than that. So your substitute decision maker will make medical decisions for you if you're incapable of communicating them on your own behalf. And they will give consent to the healthcare provider for either doing something or not doing something or stopping something that's already been started. So, starting a treatment, withholding a treatment, or withdrawing a treatment. And healthcare providers under the consent and capacity laws in Ontario are required to get consent in all 3 of those cases, and they'll get them from your substitute decision maker. You can have more than one substitute decision maker, and I'll talk a little bit more about that. So everyone in Ontario has a substitute decision maker automatically under the law. There's a list of who is at the, it's a rank-ordered list of who the substitute decision makers would be, and I'll show you the list. So even if you haven't appointed a substitute decision maker legally with a piece of paper, you have one. It's the person at the top of your list. So the guardian of the person, that's if you were put under the public guardian, if your care was put under the public guardian. Number 2 is attorney named in a power of attorney for personal care. So that's the legal document where you can name your substitute decision maker. If you don't do that, it automatically, and your case hasn't been taken to the Consent and Capacity Board, which is number 3. So in 99% of the cases, 1, 2, and 3 don't hold, or 99.9. The first person on the list is your spouse or partner. That's your substitute decision maker, if you have a spouse or a partner. If you don't, it defaults to your children, and all of them. You can have more than one substitute decision maker. So if you don't name anybody, it defaults to all of them, and then it goes down the list. So if my substitute decision maker under the law is my husband, if I decide that I don't want him because he's not going to act in my best interest, because he disagrees with what I wish at the end of my life, I need to fill out a power of attorney for personal care in order to name who I want to act on my behalf. And in the workbook that we've given you, there's a link to the Attorney General's site. You can download that form, you can fill it out. It has to be witnessed by 2 people who aren't your substitute decision maker. And it's different from the power of attorney for financial. So this is purely for health and personal care. And personal care includes things like housing and all of that kind of thing. So there are certain things under the law. Your substitute decision maker has to be 16. They have to be capable. They can't be prohibited from you in some court order. They have to be available and willing. Available doesn't mean present in the room. It can be, available by phone, by whatever, but they have to be willing to do it. And the most important thing is they have to make their decisions, and this is in the law, based on your expressed wishes, what we talked about in numbers 1 and 2, and if they don't know them, in your best interest, based on what they know about you. So these are the important questions. How do I decide? And for some of us, it's straightforward and, we don't need to think about them. But for many people, it's not. And the first one is the most important. You need to feel that the person will make decisions in your best interest and based on your wishes, not in their own. And that's very difficult. And that's why we need to have conversations. Because the only way they'll know your wishes is if you talk about it. Can they communicate clearly, and will they be able to make difficult decisions? Is that something that they're able to do? And again, you need to talk about them with it. And are they willing and available? So I talked about consent. I want to reiterate this because people often get this wrong, that healthcare providers must turn to you for consent if you're capable. And I think we've all had experiences with the situation where, if you have an elderly parent. I had this experience with my mother, where she'd be lying in the bed and somebody would come in and say, well, does your mother want this? And I'd say, well, ask her. Like, she's fully capable of telling you. So we must turn as healthcare providers to the patient or to the substitute decision maker. And wishes are not consent. This is one of the most important messages that I hope you'll get from this morning. We express our wishes to inform our substitute decision maker, but our wishes do not give a doctor consent to do or not do something under Ontario law. And then have the talk. And so, as I said, it's not easy, but it's important. And I want to share with you some conversation starters to help us get it going. But how many in the room have actually had the opportunity to talk with family about this? Okay, that's great. That's good. Less than half of Canadians have actually had these conversations. Shockingly, only 9% have had them with their physician. More people have had them with their lawyers than their doctors. So that really sort of surprised us. So as I said, conversations need to begin early, and I'd like to just share with you a short video that that shows the importance of these conversations from a variety of people's perspectives.
I would guess there's a big percentage of people don't like to talk about it. And there's a big percentage of people that it happens suddenly, you never get a chance to talk about it.
Well, of course, we are from the age that things weren't talked about.
It's not part of, hey, what'd you have for supper last night?
You've got to know what to do, what you want done.
We have to talk about this. We should talk about it so that when and if this happens, you get the care that you want.
The same day I came in, they told me I had leukemia. You can't see the leukemia going away. My wife and I have talked about pretty well everything.
Well, we did talk when you were in the hospital.
Oh yeah, I guess
And you
so.
did make the decision. We've talked since then and before that a little bit.
What did I decide?
You decided that you didn't want any CPR and that you didn't want resuscitation.
I still think that.
It's very difficult for a family member to make that decision if there's been no discussion. Most of the time we wait too late. We're often in a critical situation when we're asking those questions.
So it is new to us to talk openly about private things. I think it takes a while to get comfortable because it is a privacy thing, eh? Even with your own family. It's not so simple to say what you want or what you don't want.
We're in a situation where we're having to communicate with family members about decisions to either apply or continue or withdraw life-sustaining treatments. Frequently you hear, oh, I don't know what Mom would have wanted. Mom never told me or Mom never talked to me about this. And so the family then in that acute moment has to struggle with helping us make decisions with what Mom would have wanted. And it would have been so much easier had Mom communicated to her family in advance what her wishes, what her preferences, what her values would have been.
And 15 years ago, people didn't talk about dying.
They were still going to die.
Yeah, that's true.
I do a lot of interacting with families of critically ill patients because most critically ill patients can't communicate themselves or only minimally. By and large, people are very glad. Their family members are really glad to have this on the table.
The most important person to communicate to is that person who will represent you in the event that you're unwell and not able to speak. My plan or my wishes would be that I would want this or that I would not want that.
My wife and I have talked about pretty well everything. She knows what I want.
But the main decisions are that you've decided what you would like and not what somebody else would like.
That's right.
Particularly.
That's right. Not a fuss for one thing, not a big flurry.
Yeah, and not a crisis decision.
No.
I'm certainly glad that you and I have had the discussion.
So then the kids can't say to you, what did you do that for?
Exactly. Exactly. And
Well, I didn't do it on my own. The old girls said that.
Okay, so this can be the hardest part, is to actually start having the conversations. And so we've got some tips, just things to think about and to help people initiate this. First of all, who do you need to talk to? And that depends on who the people in your circle are. And when's the next good time to do this? Family holidays, we do a campaign that says let's talk turkey around Thanksgiving every year to get people to talk when their family's around the table. The cottage, dinner, family dinners. before the kids go to college, when a new baby's coming into the family. Life transitions, family transitions are a good time to open the door. And where? Again, one thing that really works for people when they're talking about sensitive things is to do it in the car. I've done a lot of work in my life around sexual health and sexuality education, and we always talked about talking to your teenagers about sexuality in the car, so you don't have to make eye contact, have the conversation. If people are uncomfortable talking about end of life, that can be another opportunity for them. So again, you think about these things in advance. And then conversation starters. And remember what we talked about, how it's a gift to your family. So, you know, I need your help with something. And remember how, you know, Grandma died? I want to talk to you about how I felt about that and the kinds of experience she had and what I would want that she had and what I might not want. Or I was thinking about what happened to so-and-so. And even though I'm healthy and I'm okay right now, I know that eventually I'm going to die, and so I need to talk to you about this. You can say, I've written some things down in a workbook, and I'd like to share it with you, and then can we talk about it? Or you could say, I was at the community center this morning, and these people kept telling me I should talk about this. Our videos are on YouTube. You could send somebody a link and say, watch this, and then I want to talk about it. And there's things you need to think about before you have the conversation, and we need to be ready to have the conversation. You know, some people write a letter to themselves. Expressing your wishes in writing and revisiting them and thinking about them helps you articulate it in your own mind. You can have a conversation with somebody who's, you know, a good friend who is sort of, that you're less worried about the impact that it's going to have on them than your family members. And it's really important that if you have these discussions with your family and there's disagreement, and there very well may be, about your wishes, that's okay and that's important. Better people disagree now, and you can sort it out, best of your ability, than they disagree when you're lying somewhere and capable of speaking. You can, in a power of attorney for personal care, you can appoint more than one substitute decision maker. You can stipulate what you want to happen in the situation of a conflict if you want one person to make the decision. And you can also express your wishes on that same form. So you can write down your wishes. But remember, it's not an advance directive or a living will. Those words have no legal meaning in Ontario. The doctor can't look at that and say, oh, well, she wanted, you know, she didn't want CPR. They have to ask their substitute decision maker. And then document your wishes. And we have the workbook. There's other things that you can do. You can make an audio tape, a videotape, and then share your wishes with people. And then remember to review your wishes at, you know, on a regular basis at major life events, certainly if you get diagnosed with a chronic illness, and continuously after that. So I'd just like to end again with a little bit of a personal story. Those are my daughters, Allison and Kate. And a few years ago, when I started getting involved in all of this, I hadn't had these conversations with my kids. My husband and I had talked about a lot of things in terms of our values, so we had a pretty good sense. We've had much more in-depth conversations now. But, you know, I sat down with my girls one day, Paul and I did it at the dinner table, and, you know, I said, like, I know you're not going to want to talk about this, but it's really important to me. And I introduced it by saying, remember when Grandma died and how it was really hard for us to lose her, but remember how Elaine and I were able to get through it and, you know, and deal with it. And I said, now I'm at peace with it because Grandma talked to me about these things. So you're doing me a favor and you're doing yourselves a favor. And so I sat down with them and I shared the things that I valued, and I shared some of the what-ifs with them, and it wasn't necessarily comfortable, and we do revisit it and will revisit it, but it was important to me. So It's about conversations and our wishes and our decisions, and it's certainly how we take care of each other. So I welcome questions.
Thank you, Louise. We'll give you a few minutes just to catch yourself, and I'll, as promised or threatened or whatever, I'll just give you a little bit of a sort of a rabbinic. Firstly, I think what became very clear as you were talking that it may not be easy, but it's probably more complicated not to do it in the long run. You don't achieve anything by passing the problem on or delaying it. And in terms of the general perspective on this, one could go so far as to say that because of the fact that it avoids so many uncertainties and it makes life easier for so many individuals, as painful as it is to start it, that it would be religiously irresponsible not to. So avoiding it is really not an option. I'm not going to go so far as to say it's a sin, because we have enough sins, I don't have to add to the pile. But it's certainly something that would be not responsible to avoid. A few observations. Number one, in the things that are important to me, I would just sort of like to respectfully suggest that you should add the word legacy into there.
Thank you.
Right? Because that's one that struck me. What I want my legacy to be afterwards is a very important part of the conversation. The other issue, and probably surprised that it comes from a rabbi, is that in all of the end-of-life care, we should also add issues such as what do you want to do with your organs, right? End-of-life care. And I know that there could be some religious issues involved with it, but it's certainly on the table religiously. And certainly if a donation can save someone else's life, in Jewish law, I mean, consensually, that's absolutely not only permitted, but it's considered like a great thing to do. So that is something that you may want to add into the lexicon of the conversation. I know that in terms of issues such as organ donation, the thing that's continually stressed is you got to talk about it. You can't ruminate about it. You can't be a selfie on this, right? This got to be something which is shared with others, especially within the family. But the real major issue that a lot of people are worried about is, am I consistent with Jewish law in the things that I want? In other words, some people may say, is DNR considered to be a breach of Jewish law? Well, the long and the short of it is, in all of these questions, the answer is not easy. But generally speaking, DNR is not outside the pale. We do not push people to have to endure pain, and there's no religious mandate to say that you have to suffer. It's not something that anybody would like to impose on anyone else. So if a person gives a DNR, that's totally understood and acceptable. But people do have lots of doubts about the nuances of it, withdrawal of treatment, is it permitted, is it not permitted? So what I recommend to people is that included in their team, they should have their religious leader. Now the problem, of course, sometimes the religious leader is older than the family and say, well, what's going to happen if the religious leader is not around? So the best thing to do is not only to have a religious leader and a backup, which I guess is always a problem, you need to have backups, is basically to have an institution and the leader within that institution, so that you're getting sort of an organizational approach represented by a person. So today the head of the ecclesiastic court of the Rabbinical Council of America, for example, may be a man by the name of Gedalia Schwartz, who is certainly an eminent authority, but 50 years from now, it may be somebody whose last name is White, you know, from dark black to white. It could be all sorts of names, right? But the idea is that if you say, I want the ecclesiastical head of the Rabbinical Council of America to be consulted on issues. That covers a lot of territory. In fact, probably covers all of the territory. So that, in general speaking, I think that this is a very valuable exercise today. I think, Norma, you are heartened by the nice attendance.
Fabulous.
And actually, not only that, but surprisingly more men than you thought would show up, right? So without any further ado, Louise, are you okay to take questions? So thank you very much.
Can answer them all.
It was an extraordinary presentation, very precise, detailed, covered the whole territory, and go for it. Thank you.
Anybody? Yeah?
I have a document that seems very old. It's a power of attorney kit for Ontario.
Right.
And I don't know, someone threw the idea to me that I'm a lawyer. I
Can't hear the
use that
question.
document anymore. So I'm just wondering what
Yep.
it's saying.
She said that she has a kit, a power of attorney kit that appears to be old, and somebody told her she has to have a lawyer. There still remains a power of attorney kit on the website for the Government of Ontario. I guess it's the Attorney General Department. The kit is there, it's still relevant. It has all of the forms in it and quite good explanations. So the one that's relevant to advanced care planning is power of attorney for personal care. It's in the kit. You can use it. You do not need a lawyer to do a power of attorney for personal care. You need 2 witnesses. You have to sign it. Your witnesses have to sign it. It has to be dated. And you have to name your substitute decision maker on it. So you don't need to have a lawyer to do that. Many people do it with their lawyer as part of when they're doing their will and other future planning, but it's not necessary. And the form that's on the website is a valid form. Remember that you only need to fill that form out if you don't want the person at the top of your list. I mean, you can still do it anyway, but so if I want my husband to make decisions for me, I don't have to fill it out. If I would rather have my daughter, I need to fill it out, and she's named.
So you're saying it could be verbal, right?
No.
No?
No, not if
No?
it's not the first person on the list.
No, it is the first person.
Yeah, then you don't have to do anything.
Just tell the
Good.
person, right?
Yeah.
Communicate.
You need to communicate with the person, but you
Right.
don't need to do a legal form.
Thank you.
And it's tricky. There's some lawyers in Ontario that are very active in advocating for advanced care planning, and they've given us a lot of advice and support on the things we've developed. And what they point out, they've done some research in hospitals and long-term care settings in Ontario. You come in and they say, who's your next of kin? Or who's this person's next of kin? Well, it may not be my substitute decision maker. And so, it's important. We're also educating healthcare professionals, so they ask the right questions, or they have it documented somewhere. I mean, there's a lot of work that needs to be done on both sides, but it's certainly important.
I totally agree. By example, my mom passed away last June, and she had a situation that the crash team had to come in and whatever. If we didn't have all her ducks in a row, they wouldn't have paddled her and brought her back and given her another year or whatever. So it's 100% a conversation you fully have to have, because she didn't want to be on life support, but she did have an opportunity to be paddled and brought back.
Exactly.
So we were lucky with that because it was on the file.
So speaking about something being on the file, if there is a letter that has been thinking, my mother has written, I helped her with a letter that was very detailed, that they're aware of in her residence. But does that also mean that they can't go by that letter and they have to have a decision maker there?
In the case of an emergency where they can't get the decision maker, if they are aware of any expressed wishes, they have to follow.
Okay.
Yeah. But that's in a situation where they can't get the substitute decision.
Just about 3 weeks ago, I learned that this man had collapsed in an enormous heart attack, and he's literally dead. But the ambulance came and took him to the hospital, even though he asked not to be resuscitated verbally, and he had a document, but what happened was not in his wallet. And they jumped on it for an hour and a half. And even though the family said that this is not really his wishes, it happened at the Civic within the last 3 weeks.
There can be a big problem with communicating.
Yeah.
Wishes, not necessarily wishes, but communicating substitute decision maker, or if people don't know previous expressed wishes. It's funny because, and there's a lot of debate about this in the medical community right now. It'll get more so. CPR is the only thing the only medical treatment that we need, a written medical order to not do it, right? So it's handled very differently.
Something that was not discussed this morning.
Yeah.
I'm making funeral arrangements ahead of time. Even that, it helps the family if they know it's all in place and
absolutely
pay for it too.
And it's all part of the same, it's all part of planning for, when we're not going to be able to make our, absolutely. And one of the things that we did in the workbook was to indicate, a place where you can write if you've made other plans and where the documentations are and that kind of things. I mean, lots of times you do that with your lawyer as well.
Actually, I have a very ill daughter, and I did talk to her about her funeral arrangements. Should she have it in writing?
Her funeral arrangements?
Yeah, instead of just what she told me her wishes
I'm not
are.
actually sure what the law is around funeral arrangements. So.
Talks, I'm going
Yeah.
to okay. Find
Good
out.
idea.
This is very helpful. I agree with the idea of advanced planning. The problem I have conceptually is I know you can talk to your loved ones about their wishes in general, but because medical care is so complex, until you actually are faced by the situation, I mean, you can't, as you said, you can't anticipate every condition that a person will have. I can understand when somebody has a chronic condition, for example, if they have a serious heart condition, then you can decide, do I want to be resuscitated or not? But when you're in relatively good health, what does the advanced planning consist of other than a discussion with your loved ones about, what your philosophy of life is, and that maybe you don't want to suffer, or you do want to suffer?
That's good. I've got a couple of things to talk about in response to that. In terms of the conversation, and I can give you a personal example, and everybody's example is based on their own beliefs and values, but in my situation where I'm healthy, I don't have a chronic illness, the conversation I've had with my partner and my kids is that if something catastrophic happened to me, and I would be taken to hospital, I would want a trial in an intensive care unit to see if there's a chance that something could work. And if it appears that it's not going to work, and I'm not going to have the quality of life that I've expressed in all of my values, then it's okay to stop that life-sustaining treatment. Now that's a very broad, I mean, that could look like a number of things, and that's a very personal decision. That's the kind of conversation we can have. As we get sicker, then this moves into something we call goals of care discussion. That's very focused with the healthcare team in the context of your illness. So if I'm very sick and I'm in hospital, I can have a conversation with my doctor saying, if this, and he says to me, if this happens, we can either do this or this. We can either do CPR or not, and these are the consequences. Then I can make decisions in that very slim context, and a doctor can write orders around those decisions. But that's in the context of my health right then, of my illness right then, and those orders can be followed legally. So I totally agree with you that when we're here, we make sort of broader statements that help guide people's decisions, but when we're actually faced with this very specific illness with very specific outcomes and treatments, we can make more definitive decisions that can be written into legal medical orders. And it's a continuum. And what the research shows is that if we have those vague upscale conversations, it makes it easier to have the more detailed goals of care conversations down the line. And it also makes it easier for our substitute decision
So
maker.
a person with capacity can make a decision that they don't want any treatment at all, right?
Yeah.
They can be brought to the hospital, they're suffering from a blocked artery, the surgeon says we can unblock your artery, they can say, no, I don't want it.
Yeah.
And a substitute decision maker can make that same kind of
They
decision?
can. We
And
can
they
make,
won't be challenged?
we can make bad decisions. The law lets us make bad decisions. But what would happen is, if, let's say that they were making a decision that didn't appear to be, if my substitute decision maker was making a decision that didn't appear to be in my best interest to the healthcare team, then they've got some options. They can bring in the ethics people and have more conversations. They can take it to the consent and capacity board and have the decision made there. That doesn't happen very often, but it is a possibility. So it gets very tricky and complicated when those situations arise. But I hearken back to what the physicians in the video said about, you know, being faced in a crisis with people having to have those, you know, conversations for the first time, and how difficult that is for everybody, mostly for the family.
If wishes are not consent, how do you make the transition from wishes to consent being a decision?
Okay, so your substitute, well, you, if you're capable, make the decision based on your wishes and your values, or your substitute decision maker makes the decision based on those wishes. And then what I just described, if I'm in hospital in a very specific healthcare situation, there can be written orders that provide consent based on that very specific context. So there can be written medical orders, but they're based on that very specific context in that time period. They're not for the future. Like if I go home and come back, those orders are null and void.
So if you don't have family, and you don't have close friends that you feel could take this burden, how do you choose a substitute decision maker?
Well, that's a good question. I mean, I don't know if other people have other ideas about that. People, there's lots of people in that situation, obviously. People turn to their religious leaders to help them, either to find a substitute decision maker. If they don't have, let's say you don't have a substitute decision maker, and you end up in a situation where decisions have to be made, then what happens is the healthcare team makes them in your best interest, what they perceive as your best interest. If they were aware that you expressed your wishes in writing, well, that doesn't give them consent. It provides the framework. They're obligated to act in the context of your expressed wishes if they know them. So that would guide their care as well. But that's very important. You know, there's and other people in the room probably know more about it than I do, but there's a lot of work going on now in palliative care with people who don't have homes, who are homeless, and you may not have family and friends.
If you don't have anyone, then wouldn't you say your doctor would be the best person?
No, they can't be. Well, they will act in your best interest as they perceive it, but they can't legally be appointed as your substitute decision maker.
If you go to the hospital from a nursing home or a retirement home, and it's through emergency, then the nursing home or retirement home must send your requests along with it. And right away, the doctor, before he will do any treatment, will look for that piece of paper.
Yeah, they should do that. It doesn't always happen, unfortunately. And they should speak to the person substitute decision maker, if it's possible.
I have seen laminated cards made up to say, I do not want DNR, signed by the person, dated, and their lawyer has signed it as well.
Other questions?
I don't have questions, as much as a heartfelt thank you. I'm going actually this week to do my will with all this, and you have clarified exactly what I have to do and what document I have to write before I go. So thank you.
Well, thank you for that. I'm glad.
This is not a question so much as a comment, a recent experience where my mother has congestive heart failure and has had to make repeated emergency, going to emergency for 24 hours or whatever. And I think that there's no consistency from one doctor to the other. The doctor who's on call, not on call, the doctor who's supervising emergency, maybe somebody who's just been called in to substitute and who may have no tact and is saying, if I were you, taking the family up behind the curtain where the person is and saying, if I were you, I would get in touch with your clergy. And this is the first mention to the family of what the mother's condition is. So it's, and where it was not in fact the case at all, but, or hopefully not the case at all, but I think that to rely on the staff at the emergency is not very firm.
And unfortunately, your experience is not unique.
Yeah.
We have a lot of work to do in the healthcare system to train, if I can use that word, ourselves, I'm not just in Dr. Blaine, nurses, doctors, others, to have conversations, to ask the right questions, to know what to ask. And certainly the work is unfolding in that area, but we have a ways to go. And one of our goals in doing this program is basically to incite Canadians, people, to raise this and have these conversations, because what happens often, is that if you go to your physician or you push the envelope, they're more likely to respond. I mean, it's complicated. There's a lot of issues, but I appreciate what you're saying, and it's not a unique problem.
So,
Well, just one comment. Fern and I are both social workers, and we're saying that to each other that this is where social workers can help in a hospital situation, in a hospice situation. There are always social workers available. So if you ask to speak to the social worker, they can help guide you through the process.
Thank you.
Very good point. Thank you, Louise, for a very informative and very well-balanced presentation. As a closing comment, you made an observation about the fact that only 10% of people have talked to their doctors about this. I somehow or other get the sense from a lot of people that there's a reluctance because they find doctors basically, they're in there for, let's say, a 5-minute thing. Yep. There's so much pressure on the doctors today. The whole medical system is really skewered against having long conversations with doctors. So I'm just wondering whether down the road, in terms of planning this in a viable way, that we should actually remove the doctors from the equation, because that 10% I don't think is going to get a lot better, because they don't have, I'm not saying it's critical, it's just a question, they don't have the time to sit down. This is a long conversation, it's not an easy one. So I'm just wondering whether the social work area should be one where this should be going to. But what you have done today for all of us is that within the Jewish community, I think you've opened up the conversation. You've taken the wraps off a very important issue, and there'll be a ripple effect. JJ has taken a video of it. It'll be hopefully available to the community, and it'll get people thinking. And so, in a sense, what you've been is a tremendous stress buster. So, thank you very much.
Like for the younger generation, they're not aware in the Jewish community that they have to be a member of a synagogue. I think that should be expressed to the younger generation, that they won't know.
I'll be the last to disagree with you.
Yeah.